With his eyelid slowly consumed by cancer, our patient faced an impossible choice: the sacrifice of his eye to save his life, or cling on to a bleak hope of saving his eye with topical chemotherapy. Good morning, ladies and gentlemen. I'm Dr. Banka Megha Ajay, and today we explore if topical chemotherapy in sebaceous gland carcinoma is a hit or a miss. A 57-year-old hypertensive male presented to us with pain, redness, and left upper eyelid since 5 years. He was treated as chronic blepharoconjunctivitis for almost 6 months, but on further deterioration underwent an incisional biopsy and was referred to us as histopathologically confirmed pagetoid sebaceous gland carcinoma. On examination, we note diffuse conjunctival congestion involving the entire upper palpebral conjunctiva, a thickened lid margin, meibomian gland dropout, and telangiectatic vessels. The bulbar conjunctiva clinically looked uninvolved and there were no palpable lymph nodes bilaterally. At a 17 site conjunctival map biopsy confirmed the pagetoid component extent. Therefore, a trial of mitomycin had to be discontinued because of poor tolerance. With a confusing picture due to no clear demarcation of tumor extent in the palpebral conjunctiva after an abrupt course of mitomycin, there was considerable risk in doing an eyelid sharing surgery. Hence, a repeat conjunctival map biopsy was done, and after a negative result, we proceeded with an eyelid sharing procedure with excision biopsy under frozen section control with cryotherapy and lid reconstruction with Cutler beard surgery. For almost a year and a half after that, the patient had an uneventful follow up in close monitoring with a cornea specialist for a mildly irritable eye until we noted severe papillary hypertrophy in the entire span of the upper palpebral conjunctiva and repeated a map biopsy, which confirmed recurrence of pagetoid sebaceous gland carcinoma of the papillary variant. After a reassuring PET CT, at this point, orbital exenteration seemed reasonable due to prior suboptimal response to mitomycin and unjustified ocular surface damage, leaving no useful vision with EBRT. On patient's keen insistence at eye salvage, we made a final attempt with modified 5-fluorouracil topical chemotherapy with bandage contact lens to aid patient tolerance and counseled him for strict close follow-up. Post 6 cycles of 5-fluorouracil, we can appreciate excellent clinical response with near total resolution, which was confirmed on a map biopsy with just the superolateral fornical conjunctiva positive for malignancy, which was treated with heavy triple freeze thaw cryotherapy to the concerned area and 3 more cycles of 5-fluorouracil, followed by a repeat map biopsy which showed no evidence of atypia at 6 months follow-up. Think pagetoid sebaceous carcinoma, think conjunctival map biopsy to confirm the diagnosis and extent. Alan Putterman suggested that a map biopsy helps to prognosticate and chart the further plan of action. Due to its aggressive and stubborn nature, pagetoid sebaceous carcinoma often comes as a grim indication for exenteration. However, today we have multiple studies in support of topical chemotherapy like mitomycin and 5-fluorouracil with excellent globe salvage rates. In the 2018 IGO editorial, Dr. Santosh Honavar asked if we can do better with sebaceous carcinoma. It has been 7 years to the question, and the answer continues to be yes. A customized approach based on tumor biology while respecting the oncological principles is the key. Sebaceous gland carcinoma of the pagetoid variant, the great masquerader, capable of arising from multiple structures and confusing majority of comprehensive ophthalmologists, is the most common eyelid malignancy in India. It has for the longest time cost globes and lives of many unfortunate patients. In light of today's strong evidence-based practice, it is only wise for us to use measures like conjunctival map biopsies and give our best shot at new conservative modalities before resorting to a step as drastic as exenteration. We miss all the chances we do not take, hence, we must take them more often than we do. Thank you. Yes, ma'am.
So can you just tell what are the pointers when you suspect malignancy?
Ma'am, in case of a sebaceous gland carcinoma, we need to first look at the eyelid margin. We need to check for
Yeah, which
loss.
are the type of cases where you would suspect malignancy and
Yeah, if there is features like lash loss, distortion of the eyelid margin with rounding of the posterior margin, meibomian gland dropout, abnormal telangiectatic vessels at the lid margin. These would all be features suggestive of a malignancy. And along with this, if we have diffuse conjunctival congestion, thickening of the palpebral conjunctiva, then we must suspect a pagetoid component as well. And
Okay, there's much more to it.
in a clinical profile of a patient, recurrent refractory unilateral blepharoconjunctivitis in a patient should always be suspected for
That's the point.
malignancy.
Thank you.
Thank you, ma'am.
And I have one question. Was this the only case you tried 5FU or
No,
you
this
are
is one
routinely
of
doing
those.
it?
This
You
is
ru-
one of those.
So how do you decide which cases would you take up for 5FU and which cases would you just do cryo and wait and watch?
Cryotherapy can be done only if it is a very if in the map biopsy it is in one focal component that we find it. But in the first map biopsy that the patient underwent, the pagetoid extent was in the entire superior palpebral conjunctiva. So for a case like that, we have to resort to topical chemotherapy. But in the recent last map biopsy, it was only the superotemporal one site was positive. In that case, we can go ahead with cryotherapy.
Right. So this is a very close group. So I would ask anybody if anyone has any question, you can just interrupt because we are all here to
Would you
learn.
do map biopsy for every case?
In case of sebaceous, when we are suspecting sebaceous gland carcinoma for a well-defined nodular lesion, we can proceed with excision biopsy with clinically clear margins, frozen section margin control. But if there is any component of ocular surface inflammation, bulbar or palpebral, especially remote from the lesion, then it would be wise to go ahead with pagetoid, with a map biopsy.
Right.
And when do you stop with 5FU? Like how many cycles do you think is?
We first do 6 cycles, and that's when we repeat a map biopsy to check, and then we observe for any clinical change. If there is any, like this patient developed papillary hypertrophy after a year, so
Right.
that would be another point of intervention where we would do a map biopsy.
Perfect. So that's a perfect case. So now, thank you, Dr.